Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of very crucial tips for high-impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very precious tips which may prove very, very handy in your line of duty. So I welcome you all to part 126 of our Pharmacotherapy MCQ series, Measuring in Infectious Diseases. So the first question reads, Mr. MMO, a patient presents to your clinic complaining of penile discharge and burning on urination. About 7 days ago, a week to be precise, he had unprotected sexual intercourse with a strange girl whom he met at a party while drunk under the influence of alcohol. He has no past medical history, that is, he has no known comorbidities. Currently, he takes no chronic medication and he has no known drug or food allergies. A urethral discharge smear is obtained after physical examination is done, and it reveals moderate gram-negative diplococci and many polymorphonuclear cells. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. MMO's treatment? Would it be A, 100 milligrams of doxycycline taken orally twice daily for a week, or would it be 250 milligrams of ceftriaxone administered intramuscularly as a start dose alongside 1 gram of doxycycline administered as a start dose orally, or would it be 250 milligrams of ceftriaxone administered intramuscularly as a start dose alongside a gram of azithromycin administered orally as a start dose, or would you simply settle for 250 milligrams of ceftriaxone administered as a start dose intramuscularly? I'll give you 10 seconds to choose the correct answer. I would settle for 250 milligrams of ceftriaxone administered as a start dose intramuscularly alongside a gram of azithromycin administered orally as a start dose. Remember, this patient's clinical presentation and the presence of gram-negative diplococci from his urethral smear are consistent with gonococcal infection. And as we know, the recommended regimen for gonococcal infection is ceftriaxone 250 milligrams IM as a start dose plus azithromycin 1 gram taken orally as a start dose. That makes answer C the correct answer. Now I would like to add that because of high co-infection rates, patients with gonorrhea should also be treated for chlamydia, even if the chlamydia tests negative, or if the chlamydia test emerges negative. Now, in addition, treatment of chlamydia provides dual coverage against gonorrhea, which may prevent the development of drug resistance. So that makes answer D correct. Monotherapy of ceftriaxone alone would not suffice. I would like to add that tetracyclines may be used for chlamydia alone, but they are not recommended for gonococcal infections because of increased resistance. So that explains why answers B and A are incorrect in my opinion. Let's move to the next question, please. And it reads, Mrs. NKT, a 22-year-old female patient, presents to your clinic complaining of painful ulcerative lesions on her labia bilaterally. And your physician on call makes a presumptive diagnosis of herpes labialis. He consults you as a clinical pharmacy specialist in the infectious diseases team for the best regimen for Mrs. NKT's case. So my question to you is, which of the regimens listed below would you recommend for NKT's treatment? Would it be valganciclovir 900 milligrams taken orally once daily for a week? Or would it be valacyclovir 1 gram taken orally thrice daily for a week? Or would you settle for acyclovir 800 milligrams orally twice daily for a week? Or would you settle for 400 milligrams of acyclovir administered thrice daily orally for a week? I'll give you 10 seconds to choose the correct answer. I would settle for 400 milligrams of acyclovir administered orally TDS thrice daily, that is every 8 hours for 7 days. Remember, for the first episode of herpes labialis, acyclovir 400 milligrams orally TDS is a reasonable first-line option. That makes answer D correct. Now, increasing the acyclovir dose to 800 milligrams is unnecessary for the first episode, which makes answer C incorrect. Now, I would like to add that the correct valacyclovir dose for HSV is 1 gram orally BD twice daily, not thrice daily. And that makes answer B incorrect. Then I would like to add that although valganciclovir is active against HSV, its spectrum of activity is broader than necessary. That would be an overkill. So that makes answer A incorrect from an AMS point of view. Let's move to the next question, please. And it reads, Mr. BCM, a 36-year-old male HIV seropositive patient, was once treated for secondary syphilis at your hospital because he had a diffuse rash. He also had generalized lymphadenopathy and a primary genital chancre. His CD4 count was 225 cells per microliter or per mm cubed, and he had a viral load below 47 copies per ml. He has no non-drug or food allergies, and some of his labs include an RPR titer of 1 to 64. The FDA-ABS test results were positive, and he had no neurologic nor ophthalmic concerns. The nurse administered a start dose of IM benzathine penicillin 2.4 mega units to this gentleman, Mr. BCM. "18 months later, his lab results are as follows. His RPR titer is now 1 to 128. He has a positive FDA-ABS test results, and he remains asymptomatic. A lumbar puncture reveals no WBCs. It also reveals normal glucose levels. It's negative VDRL. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. BCM's case? Now. Would you treat him with 100 milligrams of doxycycline orally twice daily for 4 weeks? Or would you administer benzathine penicillin 2.4 mega units intramuscularly once weekly for 3 consecutive weeks? Or would you administer 2.4 mega units of benzathine penicillin intramuscularly as a start dose? Or would you administer 24 mega units of aqueous penicillin G IV daily for 10 consecutive days? I'll give you 10 seconds to choose the correct answer. I would settle for 2.4 mega units of benzathine penicillin administered intramuscularly once weekly for 3 consecutive weeks. Now remember, the patient's therapy for syphilis, in my opinion, has failed, as evidenced by his RPR titer, which did not decrease by 4-fold at follow-up. Now the patient would be classified as having late latent syphilis, having previously failed treatment, in my opinion, although the possibility for reinfection is not excluded. Now, the patient is asymptomatic without symptoms. There are no clinical manifestations, so in my opinion, this would be classified as latent, or rather late latent, since it has been over a year since the primary infection occurred. Just like to add that the FDA-ABS test results may remain positive after effective treatment. Now in this case, benzathine penicillin G 2.4 mega units IM once weekly for 3 weeks is optimal for latent syphilis treatment, which makes answer B the most appropriate. I would like to add that a lumbar puncture is indicated when the RPR does not decrease by 4-fold 6 to 12 months after appropriate treatment. Now this patient's lumbar puncture was negative for neurosyphilis, thus IV penicillin G is not indicated, which makes answer D incorrect. And I would like to add that benzathine penicillin G 2.4 mega units IM start is optimal for early latent syphilis, not late latent syphilis, which makes answer C incorrect as well. And I would like to remind you that doxycycline is an alternative to penicillin for late latent syphilis, but is not recommended for this patient because he has no penicillin allergy. We are told he has no known drug or food allergy. So we'll go for first line, which in my opinion, and according to many guidelines, is IM benzathine penicillin. Let's move to the next question, please. And it reads, patient JKJ, a 34-year-old man who has sex with men, presents to your accident and emergency department complaining of tenosynovitis, petechial skin lesions, among other symptoms. He has in the past been diagnosed with gonorrhea twice. That is his past medical history. And the current diagnosis is suspected disseminated gonococcal infection, which we abbreviate as DGI. Your venerologist decides to admit this patient for treatment as an inpatient. So my question to you is, Which of the regimens listed below would be the most appropriate for the management of disseminated gonococcal infection presenting as septic arthritis in this particular patient's case? Would it be a gram of ceftriaxone infused over 30 minutes once daily for 2 weeks? Or would it be a gram of ceftriaxone infused over 30 minutes once daily for a week alongside a start dose of 1 gram of azithromycin administered orally? Or would it be 100 milligrams of doxycycline administered orally twice daily for a week? Or would you settle for 250 milligrams of ceftriaxone administered intramuscularly, start alongside a gram of azithromycin administered as a start dose orally? I'll give you 10 seconds to choose the correct answer. I would settle for B, ceftriaxone, 1 gram infused over 30 minutes once daily for a week, plus a start dose of a gram of azithromycin administered orally. Remember, this patient should receive a gram of ceftriaxone IV once daily for 7 days, plus a gram of azithromycin orally once, and that is according to the CDC STD treatment guidelines. Now, treatment for longer than 7 days, that is up to 14 days, is acceptable. However, it is still recommended to be given along with a one-time dose of azithromycin, and that makes or disqualifies answer A. Azithromycin is lacking there. Now, answer D is incorrect because it does not have the correct dose or route, and doxycycline is also missing there. Then doxycycline in answer C, in my opinion, is incorrect due to the fact that resistance levels in this bacteria to the tetracyclines has risen to very high levels. So I would settle for B. Let's move to the next question, please. And it reads, Mrs. PKG, a 25-year-old female patient, presents to your accident and emergency department complaining of a fever. A physical examination is done and it shows uterine tenderness and cervical motion pain. Your gynecologist admits this patient for empiric treatment of pelvic inflammatory disease, which we abbreviate as PID. So my question to you is, which of the therapeutic options listed below would be the most appropriate for patient PKG's case or treatment? Would it be 100 milligrams of doxycycline administered orally twice daily? Or would it be a gram of ceftriaxone infused over 30 minutes once daily, plus 500 milligrams of metronidazole infused twice daily? Or would it be 900 milligrams of clindamycin infused over 30 minutes thrice daily? Or would it be 2 grams of cefoxitin infused 4 times daily plus 100 milligrams of doxycycline administered orally or IV twice daily? I'll give you 10 seconds to choose the correct answer. So D is the correct answer. I would treat this patient with 2 grams of cefoxitin infused IV 4 times daily co-administered with 100 milligrams of doxycycline administered twice daily. Remember, this patient has what we can classify as severe infection due to the fact that she has a high fever, and she should therefore receive IV therapy, which covers both Neisseria gonorrhea, C. trachomatis, as well as anaerobic bacteria, and even streptococci, and the gram-negative rods. So answer D would give us that coverage. I would like to add that answer C does not include coverage for gram-negative rods, which makes it wrong. Then answer A does not have broad enough coverage for the potential pathogens, including Neisseria gonorrhea, but and it doesn't cover the gram-negative bacilli as well. Then answer B is also incorrect because it's still missing coverage for C. trachomatis, which could be a probable pathogen in this particular patient's clinical scenario. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly remind you to give it a thumbs up, to like it, to share it widely with your peers. And if you haven't yet done so, I would humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. And I thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next video. Thank you.